My objective is to describe the epidemiology, clinical manifestations, complications, diagnosis, pathophysiology, and treatment of eosinophilic esophagitis, and to answer the question, how do medical students cope with stress of chronic illness? So first, the epidemiology. It's more common in men than in women, although it occurs in both groups, and it's found in every age group. One thing to note is that it has an incidence of 1 in 10,000 and a prevalence of 4.296 in 10,000. This data comes from 2006. And the thing that's, I think, important to note about this is that it's more common than some other more well-known diseases, such as irritable bowel disease, for example. And just a quick review, incidence is the number of new cases in a group of people during a given set of time. So in a 1 year time, approximately one new person for every 10,000 will present with this for the first time. And prevalence is the total out of a group of people. It's important to note in this that eosinophilic esophagitis is fairly recently described, and even more recently have diagnostic criteria been set. So this is most likely a low number, and as soon as more and more physicians become familiar with this, the number will surely increase. A lot of the clinical presentation is going to be nonspecific, and it's going to change throughout a person's life. So, for example, young children that present with eosinophilic esophagitis typically present with refusal to eat and failure to thrive. Children a little bit older will often present with vomiting, epigastric pain, and chest pain. In adolescents and adults, the two most common complaints are heartburn and dysphagia. And along with the difficulty swallowing, a lot of times you also get impaction, which is where food gets stuck in the esophagus before it enters into the stomach. So in adults specifically, you're going to be looking for some key clues. One of them is going to be dysphagia, and it will typically last longer than a week. So in 66% of adults, the dysphagia, the difficulty swallowing, will last longer than a week. And then associated with that, you usually have impaction, some type of food impaction where it's stuck in the esophagus, and this is usually due to strictures within the esophagus. Now, 33% usually present with food impaction. Over half of people with eosinophilic esophagitis will also have, in conjunction with it, some other allergy. Now, heartburn, the key here is heartburn, when it's treated for a period of 8 weeks or 2 months, it doesn't go away, or the symptoms of eosinophilic esophagitis don't go away. The caveat to that is that some of the symptoms may improve, but the eosinophilia in the esophagus will not go away, it'll persist. And the reason that's important is because you can get esophageal eosinophilia with GERD, and treating the GERD with a proton pump inhibitor will cause that to go away after about a period of 8 weeks. However, with eosinophilic esophagitis, it won't go away. Now, on your lab findings, one thing that you're going to see is you're going to test for allergies of food, and specifically milk, eggs, peanuts, shellfish, peas, beef, fish, rye, tomato, and wheat. Those are the most common food allergies that are associated with EOE. Now, there's something called a RAS test and a skin prick test that's used to test for allergies, but the skin patch test has actually been shown to be have a better ability at identifying these food allergies. Periodically, eosinophilic esophagitis will present with an allergy, and there's no food allergy present, but some other environmental allergy is causing the symptoms. It's also important to note the difference between eosinophilia in the plasma and eosinophilia in the tissue. So the definition of eosinophilic esophagitis implies that you're going to have eosinophilia. However, it's always going to be eosinophilia in the tissue, but anywhere from half to 100%. So this number, different studies have found different results, but a lot of the readings will say about half of patients will present with plasma eosinophilia. Now, if you do a barium esophagram, you're going to see something that looks like this, and a lot of times this is going to be confused with something called a Schatzki's ring. However, it looks the same on the esophagram. It's not the same thing. It's not a Schatzki's ring. It just appears like one, and basically it's just where the esophagus is being dented in one place. Another thing you might see on the esophagram is something called trachealization. You can see how this esophagus looks corrugated like the trachea. Now on the endoscopy, I have a list on my study guide of 14 common findings. I've only put just a few of them here. But these are the ones that are presented in all of the literature, the old literature and the new literature. So in this first picture, what you see is a bunch of white dots. This white granular looking thing can be confused for candidiasis. So, for example, Candida albicans, a yeast, can infect the esophagus and cause an appearance like this, and that's called candidal esophagitis. And it's easily treated with antifungals. However, if that's mistaken here and you treat with antifungals, it doesn't go away, then you're going to know that this isn't candidal esophagitis. It's most likely going to be indicative of an eosinophilic esophagitis. And what the white things are is they have a white exudate, and they are microabscesses of eosinophils. You're also going to see the trachealization that we saw in the esophagram, and of course you'll see strictures. Now down here at the bottom I have basically this picture and this picture are this and this from up top, but there's something else on this picture that I wanted to point out, and these are called furrows. You can see these elongated lines coming down through it. And these are called vertical furrows, and so it's indicative of an eosinophilic esophagitis. Now it's important to note, up to this point, everything we've looked at as far as the clinical presentation and findings, none of them are pathonomic. They would all only be suggestive, and the more of them you see, the more suggestive it would be. Now biopsy, here's where you get to the nuts and bolts. Now this is not a great picture, but it points out a few things. So the first thing is, in eosinophilic esophagitis, you're going to have eosinophils, so you're going to have at least greater than 15, and that's the most recent number put out by the International Gastrointestinal Eosinophil researchers, and it's also the number that was decided on in 2013 by the American College of Gastroenterology. It's also important to note, even though two major institutions have chosen this as a number, this number is still a little bit controversial. And older literature has the range being from 15 to 20, but in some cases it has been slightly less, and in a lot of cases, so if it's more, great, but if it's less, then you have to wonder if it might be from another etiology. So another thing you would look for is clustering. So if you have 3 or 4 eosinophils in a group, that's important to see. Hyperplasia, you can see how this has grown extreme, so the mucosal layer has just grown a lot larger than it normally is. And right here we have a demonstration of an elongated reed peg, and that's indicative in a biopsy. And then sometimes you're going to see the eosinophils that are degranulated, and sometimes they can be degranulated to the point that they are almost transparent. I think another important point is that for a biopsy, a lot of times it's diagnostic if you have at least 5 tissue samples to look at. And in my research for this, I saw a study where it showed where 1 biopsy was taken, and 2, and 3, and 4, and 5, and it showed the percent that accurately diagnosed the eosinophilic esophagitis, and 5 hit the 100% mark on every thing that was tested for. As we dive into the pathophysiology, the first thing you want to know is that eosinophils don't have a regular home in the esophagus. They are regularly found, and they reside in the stomach and all of the intestines, but they do not reside in the esophagus. And as we move on, the pictures are going to go away, and the rest of it's just pretty wordy, so bear with me. Note that this is a typo. It's supposed to be swallowed. Now the exact cause and etiology of eosinophilic esophagitis is not completely known and described. However, a lot of evidence has been pointing to multiple causes of EOE, and one of the main causes being allergies. This is demonstrated because, well, for example, when there's an environmental allergen, you see seasonal relief, and if it's a food allergen, you see relief from diet exclusion. So in this particular allergic reaction, these antigens activate Th2, T2 helper cells, and they release IL-5 and IL-13. The IL-5 and IL-13 will go to the esophagus and activate the epithelium to produce more cytokines. So these cytokines trigger eotaxin 3 to be produced by the esophagus. And actually 89% of people with eosinophilic esophagitis, an overexpression of this protein is predictive. So I already mentioned IL-5, but I'm going to go through all of the biomolecules one by one. It's expressed both by two different cell types, and in that it's a profibrogenic cytokine. So it works with FGF9, which I'll get to in a minute, but it causes some remodeling. IL-13 is produced by the T helper cells, and it causes an increase in the eotaxin that we just talked about. And then IL-15 will activate other T cells to produce more and other cytokines. And this thymic stromal lymphopoietin is one of the more interesting things that I found in the biomolecular process. And what it does is it acts on antigen-presenting cells, specifically the dendritic cells, and it changes what they will present to the T cells. So in effect, if they present stuff to T cells that really is no big deal, it's losing its tolerance. So it changes the tolerance mechanism. Then we have the TGF-beta 1, and it works with the thymic stromal lymphopoietin. It also contributes to remodeling, and it's produced by the eosinophils and the mast cells. And just as I said when I was talking about IL-5, there's this FGF9 that's also a profibrogenic cytokine. There's not a lot known about the mast cells specifically in this disease, but the leading theory is that the degranulation of the mast cells will lead to muscle hypertrophy and hyperplasia. The research I read on this was a little bit old and dated, but what it said is that this isn't always seen in biopsy because usually the tissues, they don't go very deep in the tissue biopsy of the esophagus because you don't want to perforate the entire thing. There was a study of microRNA. Now, you might know microRNA tends to control the transcriptions and the actions within protein synthesis and epigenetics as well. But there were upregulations of 2 microRNAs in eosinophilic esophagitis, and specifically in the esophageal tissue, downregulation of another mRNA, and then during remission, another mRNA was increased. And these are with respect to some control group. Now, if you just wanted to look in the plasma, not in the esophagus, these mRNAs would be, microRNAs would be the ones differentially expressed in the plasma. So I said allergies were associated with this, but specifically there's some genetic defects that play a big role in the allergies. So for example, eotaxin has a single nucleotide polymorphism that's associated with eosinophilic esophagitis. This thymic stromal lymphopoietin on 5q22 is also associated with it. And then there's this filaggrin, and usually it's studied in relationship to what it does on the epidermis, on the skin, because this protein helps to cross-link some keratins, and it gives some structure and some barrier. And genetic variation in this protein is seen with eczema. As a matter of fact, 50% of eczema presents with a variation in the filaggrin protein, or the gene for that protein rather. Exactly what its effect is in the esophagus is not exactly known from the research I looked at, but what the hypothesis is that it has some type of barrier role in the esophagus as well. And so I'm wondering if they mean by that that it keeps out eosinophils or if it keeps out antigens. So this CAP-N14 gene, or the Kaplan-14 protein, it was shown in one study to be a major susceptibility linkage, and so its expression is dramatically induced by IL-13. Let me change to a pencil. So IL-13 affects the expression of this gene. And the point I'm getting at right now is that there's a lot of genetics in play here, and when there's genetics in play, then maybe genetics can be used to diagnose something. So let's look at diagnosis. As of the middle of 2013, the American College of Gastroenterology put out guidelines for diagnosis. Now I have the full set of guidelines in my study guide, but this is the breakdown, this is the bare bones of it. So if you can rule out GERD, which you do that by a proton pump inhibitor, and they actually put 8 weeks. The research that I read before that had 4 to 8 weeks, but the American College of Gastroenterology says treat for GERD for 8 weeks. And if the eosinophilia is caused by GERD, then you've treated it and it should be gone. Now, so then after that, you look for, and they actually use the number 15, you look for the presence of greater than 15 eosinophils on high power focus, and then you check, does it respond to allergy treatment? If it does respond to allergy treatment, that's pretty much diagnostic, but there are also other differentials that you need to consider and rule out. Now, as early as December of 2013, a group had published a paper on a genetic diagnostic test that they created. I think this test is pretty exciting because it has a sensitivity of 96%, 98% specificity, a positive likelihood ratio of 48, and a negative likelihood ratio of 0.041. And what this thing is, it takes 96 genes, and it does everything from measuring their transcription to measuring polymorphisms and everything else. And so you take a sample of the esophagus and you run it through a quantitative PCR, and it's able to identify with really high accuracy if a patient has EOE or not. It can also differentiate between eosinophilic esophagitis and GERD. And it can also, like if you are seeing this patient for the first time or if you're doing a follow-up, this test was able to differentiate between people who were taking their medications, who were on glucocorticoids, and people who weren't. And that all has to do with the transcription ratios of different proteins. So in all the treatment, dietary is the first approach, or in the same vein, the exclusion of environmental allergens. So earlier I said we have to rule out GERD. Now, here's the problem with ruling out GERD. A person may have GERD at the same time, and so this has acid suppression. The research I was reading said that GERD can either, I'll write the capital E, GERD can either mimic EOE, or it can be caused by EOE, or it can coexist with EOE. So if eosinophilic esophagitis is causing GERD, you want to treat that. If it coexists with EOE, you want to treat it still. And if it's mimicking EOE, then you don't have to worry about the rest of these treatments. You just treat GERD. Now, topical glucocorticoids such as fluticasone, budesonide, and cliclesonide, I think I'm pronouncing that right, is they're the treatment of choice as far as pharmacological, and fluticasone is usually the first prescribed medication. Topical glucocorticoids have been shown to work as effectively as systemic steroids, so this is good news. You don't have to have all of the major side effects of systemic steroid use. Now, even with this topical use, some of this stuff can get into your system, and so if you're actually worried about that, the cliclesonide has a much lower absorption rate, and so it can be used, and it has about the same efficacy of the other two. In very rare cases of extreme stricture, esophageal dilation is required, and some of the studies I read, the newer studies, were saying that there hasn't yet been a link established between eosinophilic esophagitis and the risks of esophageal perforation. If a link is suspected, but the nature of that association is unknown. But the risk that it could happen causes people to wait until pharmacological methods are not opening up the stricture, and then they'll go in and dilate it. There are several experimental drugs that are being used, some of them that are targeting IgEs on the, some of them are targeting the interleukins, the cytokines. So there's a lot of approaches trying to come up with new treatments for the eosinophilic esophagitis. Some of them are looking promising, but they're not approved yet. They're not through clinical trials yet. Others have been just thrown out because they didn't work. Now I'm going to look at how do medical students cope with chronic disease. This isn't really something I have any familiarity with. I cope with a lot of stress, but not the stress of a chronic disease. But before we dive into this really deep topic, I thought it was important to note that I want the A+ variety if I happen to get the hepatitis. It's all about the grades. And if you didn't like the Caribbean medical school thing, it's because you just don't have a sense of humor. So most chronic stresses and the stresses associated with specific conditions have recently been reclassified in the DSM-5 as the trauma and stressor-related disorders. And so it's highlighting the association of like adjustment disorders and chronic stress as their relationship to things like PTSD, because there is a strong relationship. Just as a side note, whenever I joined the military, the recruiters they openly admitted that they were trying to identify people who were having adjustment disorder. You actually get kicked out of the military, get discharged if you have a failure to adjust, and that's by military definitions, that's within the first 6 months of service that you have problems and there's specific criteria. However, the DSM-5 is very vague on the criteria used to diagnose an adjustment disorder. And so now we know what it is. A stress associated with a chronic illness of a medical student, that would be considered some type of adjustment disorder, a chronic stress adjustment disorder. But my objective is how do you manage with that stress? And there were some things in some various psychological books that highlighted something called the elements of resilience. And so these are the elements of resilience. You can pause this and read them if you want. I'm just going to say something that I found in Gabbard's treatments of psychiatric disorders that's not mentioned in these elements of resilience. And that is, whenever you have a chronic stress, what people will tend to do is they will act out. They will take action as a way to deal with their stress. So by action, I mean they may get in trouble at work, or they may even commit suicide. So there's a lot of actions associated with dealing with chronic stress. And what Gabbard emphasizes is that we can turn that action into a verbal vent. And so the best thing that you can do, and it cannot be overemphasized, is that you put your stress and your feelings into words and you just vent. You complain, you find somebody to talk about it with, you do whatever you have to do verbally so that you don't get to that. And so now here's the prescription for resilience. This was published in a 2004 book. And I don't actually have this in my works cited on the study guide because I copied this out of a book that cited it, and I cited the book that I copied it out that cited it. So go ahead and pause this and read these if you would like. And after you're done, I have a bit of a challenge for you to identify these characteristics of resilience. So this is one of the best Will Smith clips from Fresh Prince of Bel-Air that I've ever watched. And so go to this YouTube video, skip to 2 minutes and 27 seconds into the video, and then start writing down all those key elements of resilience that you identify in Smith, including the verbalization that I mentioned from Gabbard's. So I already gave you one. He's going to verbalize his feelings. And the point of this is that you can see the coping mechanism that is used in his particular stress is the same coping mechanism that can be used in the stress that medical students deal with for chronic disease.